Buenas tardes. Buenas tardes. Bon après-midi. Good afternoon. As our president, Madam Annette Kennedy, says, I think we can do better. Good afternoon. Right, that's great. Thank you. I am Eulalia Juvé. My nickname is Lala. I'm from Barcelona, and I'm an ICN board member. Welcome to this afternoon session on the future of nursing regulation and current key issues, challenges, and opportunities moving forward. This is a two-part session, focusing first on the state of nursing regulation and on regulatory issues and nurse prescription, with two prominent invited speakers coming from the United States and from Spain. And the second part, that's a panel discussion with several prominent participants from Ghana, Ireland, the United States, and Australia. This second part is going to be conducted by our ICN First Vice President, Pamela Cipriano from the United States. So let's start this first part. Pleased to welcome Dr. David Benson, who's Chief Executive Officer at the National Council of State Boards of Nursing in the United States, and acknowledged as global expert in nursing and regulatory policy, introducing the state of nursing regulation. Please welcome Dr. David Benson.
Thank you very much, Lala. Today, as this Congress speeds towards its conclusion, I'm delighted to have the opportunity to talk about a topic that is central to the future of the nursing profession and has been a passion of mine for 4 decades. A topic that not only defines what it is to be a nurse, but also a topic that enables safe services to be delivered in ways that meet contemporary needs. Nurse regulation protects patients and populations. It shapes the profession and provides a means of modernizing service delivery. It is a powerful tool, and far too often it's overlooked. But our current regulatory model was born in the industrial era. Yet today we are living in a complex, dynamic, globally connected digital world. So as we head towards the celebration of Nightingale's bicentennial, we must redefine the way we are regulated. This must be a truly global endeavor and will require public, governments, regulators, and indeed the profession itself to take bold and courageous steps. Whether we have governmental models of professional regulation or co-governance models where the regulator is independent or semi-independent, we require us all to work together to deliver a new contemporary approach. So to do this, I'm going to provide 4 messages and 3 thoughts. I will elaborate on these in a moment. As you can see from this slide, the professional regulation and occupational licensure is under the spotlight. Most of the commentary is being generated by those that wish to remove regulation and let the market dominate. This is not a phenomenon unique to the United States, but is a common refrain in many parts of the world. So we need to counter some of the points that are being made by economists and libertarian groups with clear messages that demonstrate the value of regulation. Politicians are often unclear of the essential differences between, for example, regulating barbers and regulating surgeons, or indeed nurses and tree trimmers. They refer to all of us as collectively as occupations. We know that the level of risk associated with these different professions is very different. You can choose who cuts your hair, and if they don't do a good job, in a couple of weeks, it's okay. But if you're unconscious, you can't interview your nurse or your doctor. You cannot observe their outcomes. So other means of protecting the public are essential. Joint research that was conducted with 7 professionals and led by nursing has identified that we have taken it for granted that the professional regulation protects the public. Now, this is a big mistake. Silence is not an option. Nursing and other disciplines need to demonstrate and promote the true value of professional regulation, and in particular, its impact on safety, access, and cost. So, for my first message, it is as follows. We must make the argument that professional regulation is not only necessary, but it is essential for access to safe, effective, and efficient health systems. We need to be clear that the market cannot protect the most vulnerable, and deregulation is not the best solution for increasing mobility. If universal health coverage is to be achieved, regulators must play a full part. They must work together to facilitate mobility while simultaneously making sure that bad actors do not go undetected and move with impunity, leaving a trail of chaos and grief behind. In terms of coverage, the context is certainly changing. One problem is that occupational licensing is no longer the exclusive domain of the health professions, and some jurisdictions, it would seem to me at least, that the legislatures can be persuaded to license almost anyone. So while I will give some examples from the United States, the figures are very similar in different parts of the world. In the United States in 1950, 1 in 20 people required a license to practice. The figure now is 1 in 3. Now, we know from the UN High Commission report that despite the recession, health jobs did in fact increase. But while the potential power of the regulator, through virtue of numbers, is on the increase, we need to remember that licensure may not be the right solution for all professions or occupations. We need to look at alternatives, specifically when the level of risk is low. So in short, licensure should not be the default option for all. So allow me to provide my second takeaway point. We need to recognize, organize, and harness the growth of licensure. Ensure it is used as intended to protect the public, and that regulatory interventions are proportionate to the level of risk. Occupational licensure, as I showed a moment ago, is certainly in the headlines. We need to know that the challenges that we face are addressed by the professions in persuading governments to do the right thing at the right time. It is not just about advocating for change for the sake of it. I'm advocating for change because it's essential. This slide shows the changing population support ratio. This is the global figures. It's the number of people that are in employment compared to the number of people that are retired. And what you can see is that we are now in a rapid decline of the number of people that are in employment compared to those that are retired. This is a success. Health systems are working. People are living longer, but with that longevity comes more complex care needs, some of them physical and others mental health. So we need to think differently. With fewer people per retiree, we'll need to ensure that health professionals are doing the right things, only the things that they can do. Assistive personnel, robots, and other technology systems will change and provide some support. They may even be part of the team, but we need to think about and we need to inform that debate. It does not simply happen to us. We actually must be proactive. More of the same will not work because everyone will be competing for an increasingly smaller number of individuals. The lawyers, the accountants, the architects, indeed nursing, will have to fight hard to attract workers. So let me think about this message that I think is important. We must embrace this new order where the continuum of practice, working in teams, and figure out where automation actually fits in a way that actually supports us and does not interfere with the things that we do best. Richard and Daniel Susskind wrote a book, The Future of Professions, and although they focus on the legal profession, their work is very informative in terms of how we use and how we might use experts in the future. So my final message focuses on research. Recently, the National Council of State Boards of Nursing worked with a diverse team of regulators from around the world, representatives from both the nursing profession, but from other disciplines as well, and indeed from intergovernmental agencies such as OECD. We were able to identify 25 specific regulatory trends. And we decided that we would try and push the boundaries, try and see where these trends would take us, so that if they were favorable, we could accelerate those trends. If they were unfavorable, we could then decide how we might course correct. This report, the one on the left, was entitled Regulation 2030, First Steps in a Journey. And it lays out a number of solutions for regulatory change that are important as we move forward. Now, having said earlier that health professions have indeed not been sufficiently proactive in providing the evidence, the truth is the evidence is there. And as a result of working with regulators from 10 different countries, 15 regulators in total, and I want to really thank my colleagues in the United States and Canada, New Zealand and Australia, from Kenya, Swaziland and Ghana, from the Lebanon, the Dominican Republic, Spain and here in Singapore, the work that they did to help to pool together and curate the evidence that we can all use. So when we see those headlines in our papers, we have the answers that can counter them, and they are based on evidence, not opinion, but evidence. And on that point, I just want to show you this table. This is some work that hasn't been published yet. It will be published in October. But this is an analysis of who are the scholars that are contributing to the professional licensing and occupational licensing research. And as you can see, in addition to the average scores, which is the first column, nursing, the law, economists, educators, and medicine are the most prolific of all professions that are writing on this topic. So when you ask the question, so who has written the most? Well, the surprise is, joint first comes the legal profession and nursing. The legal profession and nursing. But if you look at the quality of that work, the research base, nursing comes first. And we should be proud of that. Our medical colleagues, only 29.4% of their work is research-based. Maybe we have to bring them on board and help them along so that we actually make progress that we need. So, the motto of the United States can be found on the back of every dollar bill. In today's policy climate, in God we may trust, but everyone else needs to bring evidence that talks to your audience. So just remember that. So let me just give you three quick final thoughts. The public are demanding higher standards of safety, quality, and sensitivity to their needs. The profession is demanding increased autonomy, recognition, and opportunity. And politicians are looking for the most efficient, effective, and proportionate models of regulation. Failure to meet these demands and expectations will be detrimental to all of us. A regulatory model stuck in the past will be viewed as a failure, and politicians often reward failure by taking power away from the regulators and punishing the profession. So we need to be really proactive. So I just want to call to all of you to go confidently in the direction of reformed and improved regulation. Act in concert to deliver the future that improves access, maintains public safety, and minimizes costs. And most importantly, collaborate in designing a future that lifts all of the world's people towards improved health and well-being. Thank you very much for your attention.
Thank you very much, David. Our second speaker is Dr. Mercedes Gómez del Pulgar, Director of the Research Institute Nurses of the Spanish General Council of Nursing and coordinator of an international project on best practices in patient safety. Mercedes is going to present us their experience on regulatory issues on nursing prescription. Please welcome Mercedes Gómez del Pulgar.
Buenas tardes. Soy la directora del Instituto Español de Investigación Enfermera del Consejo General, no la directora del Consejo General. Primero de todo quiero dar las gracias a la organización por la invitación para estar aquí en esta sesión de parte del Consejo General de Enfermería y, por supuesto, de mi parte. El tema que voy a exponer en estos 10 minutos es el proceso de regulación que se ha llevado a cabo para conseguir que esté aprobada actualmente la prescripción enfermera en España. Este proceso de regulación ha sido un proceso muy largo, un proceso en el que se han invertido muchos esfuerzos y en el que ha habido que justificar, como siempre tenemos que estar haciendo los enfermeros cada vez que hay que regular algo, cada vez que hay que demostrar algo, ha habido que justificar que somos capaces y que somos competentes para prescribir y esa va a ser la primera parte de la exposición. Los procesos de atención integral de salud requieren que haya una integración entre los mismos, requieren que haya una continuidad asistencial y requieren una coordinación entre los diferentes profesionales. ¿Para qué? Para evitar el fraccionamiento y la simple superposición entre procesos asistenciales atendidos por distintos titulados o especialistas. Teniendo en cuenta esta integración, vemos que el proceso asistencial, el proceso médico y el proceso enfermero realmente es un proceso muy similar. El médico diagnostica después de la valoración, la enfermera valora, diagnostica y se proponen unas actividades y se proponen unas intervenciones. La prescripción es un resultado de esa valoración y de ese diagnóstico y, como consecuencia, una intervención que hay que realizar. Cuando se comenzó a hablar de regulación enfermera en España, una de las resistencias que había por parte del colectivo médico era que las enfermeras no diagnosticábamos. Entonces hubo que justificar, y gracias a que hoy en día la Directiva Europea de Cualificaciones en su última su última modificación, ha incluido el diagnóstico independiente como una de las 8 competencias que tenemos los enfermeros en Europa. De tal manera que esto fue uno de los argumentos que nos sirvió para decir, no es que estamos diagnosticando habitualmente, es que además está regulado a nivel europeo que tenemos esta competencia, además de muchas más, y además como una competencia independiente, al igual que las intervenciones que realizamos como enfermeros. Como decía, esta es la competencia diagnóstica, competencia para diagnosticar de manera independiente, para programar, organizar y administrar los cuidados de enfermería al tratar a los pacientes. A nivel nacional, en España existe la Ley de Ordenación de Profesiones Sanitarias, una ley que define cuáles son las funciones que tenemos los enfermeros en nuestro país y que dota también de la autonomía profesional dentro de nuestro ámbito competencial. Además de esta ley, en todos los planes de estudio que actualmente están aprobados y que están unificados, existen 3 competencias que están relacionadas con la prescripción enfermera, que son las competencias de uso e indicación y dispensación de medicamentos y productos sanitarios. Todo esto va conformando una justificación para llegar a que en el 2009 se aprobará la nueva ley del medicamento que modifica las anteriores leyes y en la que ya se incorpora que los enfermeros podemos ser prescriptores. Claro, esta ley, como digo, del 2009, había que concretarla en un Real Decreto y ese Real Decreto, como vamos a ver más adelante, han tenido que pasar 10 años para que pudiera ver la luz. En la ley del medicamento se recogen diferentes tipos de prescripción. ¿Cómo podemos prescribir los enfermeros en España? Pues hay una parte que es una prescripción autónoma, que es la que tiene que ver o en la que podemos prescribir todos los medicamentos que no están sujetos a prescripción médica, además de todos los productos sanitarios. Hay una prescripción colaborativa, que se refiere a la prescripción de medicamentos sujetos a prescripción médica, y que no es que no la podamos prescribir, sino que nos tenemos que basar en guías y en protocolos que se elaboren de manera conjunta con el regulador médico, el regulador enfermero y el Ministerio de Salud y que van a estar aprobadas por la Agencia de Calidad del Sistema Nacional de Salud. Por lo tanto, prescripción autónoma, prescripción colaborativa y, evidentemente, en esta ley existen unos requerimientos que son unas exigencias y es la acreditación como enfermeros prescriptores. Esta acreditación será tanto para los enfermeros de cuidados generales como para los enfermeros especialistas. La acreditación pasa por disponer de una experiencia profesional de 1 año, por lo tanto, hoy en día podemos decir que el 97% de los enfermeros españoles son prescriptores y están en condiciones de ser acreditados para este tipo de competencias. Hay una consideración especial que se refiere a las vacunas, que a pesar de ser medicamentos que estaban sujetos a prescripción médica, hoy en día son unos medicamentos que podemos prescribir de manera autónoma y esto es una consideración muy importante. En el Real Decreto de receta médica, aquí les muestro la receta que realizan los médicos, que si se dan cuenta es exactamente la misma que tenemos los enfermeros, nada más que ellos ponen receta médica y en la nuestra pone orden de dispensación, pero todo lo demás, todos los campos son los mismos. Por lo tanto, la competencia de uso y dispensación de medicamentos tan solo se diferencia la receta médica en este apartado. Como les decía, ha sido un proceso muy largo, un proceso que ha durado, desde que se aprobó la ley del medicamento, ha durado 10 años. Ha habido 90 versiones desde el Real Decreto, desde la primera versión del 2010 hasta el año 2015, en la que se aprobó este Real Decreto que bajaba la realidad la ley del medicamento, 90 versiones, 2 trámites de audiencia y 3 proposiciones no de ley, y justo cuando se aprueba en el 2015 este Real Decreto, en el último momento se cambia un párrafo y resulta que todo lo que se había negociado hasta ese momento para poder ser enfermeros prescriptores se relaciona a la orden médica otra vez. Nos dicen que para poder prescribir los medicamentos no sujetos a prescripción médica no lo podemos hacer en base a protocolos, sino que debe haber un diagnóstico del médico, debe haber una orden del médico y el médico nos tiene que indicar cuáles son los protocolos exactamente que debemos seguir. De tal manera que, bueno, pues evidentemente esto han tenido que pasar otros 3 años para que pudiera ver la luz el Real Decreto que actualmente es el que está vigente, con muchas negociaciones, otra vez a demostrar, otra vez bueno, pues a luchar, como siempre nos toca. Pero bueno, afortunadamente en octubre, justo 3 años después, se ha conseguido modificar ese párrafo y se ha conseguido disponer del Real Decreto que acerca a la realidad la ley del medicamento y que por fin, como digo, los enfermeros españoles, el 97% de los enfermeros españoles, podemos decir que están en condiciones de ser prescriptores. Esta es la experiencia, creo que no es ajena a muchas realidades, pero en cuanto a la lucha y en cuanto al esfuerzo. Pero bueno, afortunadamente hoy estamos en esta situación. Creo que me ajusto al tiempo. Muchísimas gracias.
Well, thank you both speakers, and please stay on the stage. Now our Vice President, Pamela Cipriano, and the rest of the panelists, you are invited to the stage. Thank you so much. I say goodbye.
We have all the mics on? Great, thank you. We have just heard from 2 experts speaking to us about 2 very important trends, one being to continue to focus on some of the basic protections of regulation, but be prepared to move into the future with new models. And we've heard about the autonomous prescribing competencies and journey, and sometimes how long it takes to get the protections and requirements in regulation. We now have a number of other experts from around the world who are going to share with you innovations in their countries. And so I'm going to introduce all of the panelists first, and then we will go in the order in which they've been introduced and that are in your program and the app. To my left and your right, we have Mr. Felix Nyante from Ghana. He's the Registrar of the Nursing and Midwifery Council of Ghana. Then we have Dr. Anne-Marie Ryan. Dr. Anne-Marie Ryan from Ireland. She is Director of Operations with the Nursing and Midwifery Board of Ireland. Next we have Dr. Franklin Schaefer from the United States, who is President and Chief Executive Officer of the Commission on Graduates of Foreign Nursing Schools International. Then Ms. Tanya Vogt from Australia, who is the Executive Officer of the Nursing and Midwifery Board of Australia. And not listed in the program, but is on the app, we have Dr. Ying Wu from China. She is Dean and Professor of Capital Medical University School of Nursing in Beijing. And she is also the Vice President of the Chinese Nursing Association and a board member of ICN. Felix, let me turn to you.
So, let me take this opportunity to thank the organizers of this program and for the opportunity to speak in this plenary. In Ghana, the innovation that we have put our hands on the wheels to do is to move away from paper-based tests to computer-based tests. We regulate 22 programs in nursing and midwifery, and these programs are run in 88 institutions across the country, and annually we turn out over 18,000 nurses and midwives. And so if you figure out how laborious the licensing exams would be, then it leaves much to be desired. But we have realized that in this age and time, if we rest our performance on ICT, we can accelerate our performance. And so we didn't have the resources, we didn't have the technical know-how, but we saw the vision, and we wrote a proposal to the Netherlands Embassy, to Norfolk in the Netherlands, and they gave us tremendous financial and technical support. They came in to train us, and then they gave us financial support as well. The little resources that we used, we also committed it to ICT infrastructure, and as we speak now, we've been able to connect the entire country, and you can sit at the south and then take your licensing exams online. And that is what Ghana has done. And this is the first of its kind in the West African sub-region among 7 countries. And it is on record. The benefits that have accrued to us is that we have cut down the number of days that we used to process the licensing exams. It used to be 70 days. But it is interesting to note that it has been brought down to as low as 10 days. What it means is that our nurses and midwives will be readily available to the job market. So, distinguished ladies and gentlemen, this is what Ghana has done in terms of revamping our operations. Thank you very much.
Anne-Marie.
Thank you. Thank you very much. And like that, I'm delighted to be able to share a small example that I have from Ireland in relation to innovation regarding regulation. And I suppose I'm looking at innovation from the point of view that innovation is transformation, and regulation, as we know, it's about control of the activity by rules. So my example relates to the regulation of advanced practice nursing in Ireland. And the transformation occurred when I was trying to develop a policy. I had the privilege to do this in the Department of Health, to demonstrate that nurses could address some of the critical problems that we had, or critical challenges that we had in the health service at the time. And this is about providing access to the health services, that nurses could assist in reducing some of the waiting lists that we had, some of the critical ones, and also to avoid unnecessary hospital admissions. So within this particular policy that we are trialling, and is nearly finished now, is that nurses were selected to undergo training as advanced nurse practitioners in the areas of chronic disease management, which included rheumatology and respiratory, older person care, and unscheduled care, which is our emergency departments, and you know that 48 hours. And what we were trying to do with this was, when we did this, we needed then to revise completely the regulatory structure, because the goal of what we were trying to do was to have 700 advanced nurse practitioners, or 2% of the nursing population, as advanced nurse practitioners by 2021. So what we had to do was we had to re-examine the regulatory model. Now, we had advanced nurse practitioners in Ireland since 2001. They only had been regulated since 2010, but we only had 160 of them in that long period of time. And the issues when we went out, when we looked at the evidence and then we went out on consultation with the stakeholders, they told us that being 7 years qualified to become an advanced nurse practitioner was too long, particularly when 5 years of that time had to be in the particular specialist area. They also had, within those original regulations, there was a match between the person and the post. So what we wanted to do then was to decouple the post from the person and go back to what was the essence of regulation and bring it back to the education preparation. So within that, the new regulations for advanced nurse practitioners came into effect in June 2018. And the overall impact of this will have that we have, there'll be immediate registration of nurses who complete an approved programme of education. But in particular, we also now have a model where we can recognise nurses who do, if you like, an eclectic developmental type of way to become an advanced nurse practitioner. And that also includes nurses who have gained their qualifications in other jurisdictions. So we can recognise nurses from other jurisdictions. So within this innovation, we have streamlined our processes without losing our regulatory mandate of protecting the public. I suppose the lessons out of this is that regulation needs to be relevant to the health services to meet patient need. It also needs to be, as David has said, proportionate for the purpose that it serves. We've gone on a long expansion of our role, and I suppose one of the things that I'm particularly delighted about was that when Annette Kennedy was in her developmental role in the INMO, we worked very hard together to get nurse prescribing of ionising radiation and of medicines, but also then to bring in the advanced nurse practitioner. So the other big lesson I would say is that regulators need to evaluate their processes regularly. They need to use the data that they have. They need to do the horizon scanning that David has mentioned, because we need to be relevant to the health service and being responsive to the developments in service delivery, education provision, technological advances, while minding our brief to protect the public. Thank you.
Thank you. Franklin.
First of all, I'd like to thank all of you for staying on Friday, this hour of the day, in the beautiful weather. I think that when we talk about innovation within the United States, I also think about innovation in our neighboring Canada as well as Mexico. We've had the opportunity in the United States to learn from each other through the harmonization that's taking place in Canada, to the compact states that's taking place within the United States. Also, the National Council for State Boards of Nursing, under David's direction, has also taken the opportunity to recognize, as we look at these trade agreements, that the Federal Trade Commission can be one of our best partners as we try to move forward advanced practice nursing. We are moving to more and more every day to a full scope practice for all of our advanced practice nurses. But while we do that, we're also shifting the skills down to a lower level nurse so that maybe they too can take full scope for their practice at the bedside or wherever they're practicing. We also are believing in the fact that it's a credentialing continuum and the care continuum. We're hopefully are moving towards thinking of care across the continuum of care, outside of the acute care, but thinking of the whole. We're also partnering with the consumer group to try to move their agenda and our agenda together, such as the American Association of Retired People. The future of nursing is housed there. I believe that the future of nursing within the United States looks very, very bright. I think we've laid the foundation for many wonderful things yet to come, and I think it's going to be an exciting area for us. I believe our leadership in nursing in the United States could take advantage of the quote, and I believe they are, that George Bernard Shaw once said, I look at things, there are those people that look at things the way they are and ask why. I look at things, and I think our leaders are looking at things in nursing in our profession and are saying, why not? I believe that we're in a very exciting time in our country. I believe that we're in a very exciting time in North America, and I believe that we're in a very exciting time around the world. We have the opportunity before us in the Year of the Nurse to get the data that we need, that we'll be able to take the science of nursing with the research that David pointed out before, using sigma theta tau, and to try to move the research agenda around the globe by developing more researchers. I think it's a very exciting world in which we live in. And according to Walt Disney, it's a small world after all. Thank you.
Tanya, please tell us about Australia.
Thank you. I'd just like to thank ICN for the privilege of being able to share today an example from Australia that I think is best practice regulation. And it was a journey that we went through in reviewing our codes of conduct. And all of you will know in the audience that codes of conduct are or codes of ethics are very important regulatory tools. They're essential in the regulatory toolbox in order to set the professional tone for our profession. The Nursing Midwifery Board regulates both nurses and midwives, so our review included the codes of conduct for midwifery as well. Of course, the journey that the board went on to review these codes of conduct that hadn't been reviewed since 2009 was evidence-based, research-based. We analysed notifications, but the critical thing I think that we did in this review process was we actually engaged not just with our professions, but importantly with our professional associations and our unions and consumers as well.
Tanya, can you put your mic closer?
Oh, sorry. The codes in Australia, in developing the codes, we worked through an innovative process of looking again also at best practice internationally, and in early 2017 we released the codes of conduct. One of the key changes that we made in the codes of conduct was to importantly focus on the needs of our Aboriginal and Torres Strait Islander, our Indigenous people in Australia. And we worked closely with the Congress of Aboriginal and Torres Strait Islander Nurses and Midwives Association in Australia, who provided leadership for the board and the professional associations and the union in this journey in the way that we described our expectations with respect to the care that we expected of our nurses and midwives for our Indigenous people. Interestingly, when the codes were released in 2017, soon after we actually started to get some adverse publicity from very right-wing groups in Australia. It was actually quite sensationalist, inflammatory, and it really erroneously represented the position that the board had taken in the codes. It was very difficult to manage and really was that classic fake news. The board went through a very challenging time at that point. And I suppose from our perspective, our colleagues from the associations and the union could have walked away, I suppose, and let the board deal with it, but they didn't. The most beautiful thing was, as a profession, we actually stood up together. We released a joint statement, so the Australian College of Nursing, the Australian Nursing and Midwifery Federation, the Australian College of Midwives and the Congress of Aboriginal and Torres Strait Islander Nurses and Midwives all stood up with a joint statement clearly supporting the position that had been taken in the codes as best representing the way that the professions expected the care of our Indigenous people to be delivered. So my message today, and I think it picks up on some things that David said earlier, is that the more that we can work together, the more that we can improve the safety of the people that we care for, and the more that we stand up as a profession together, the more we're respected. We do have individual responsibilities, the regulator, the unions and the professional associations, but with respect and shared interest in improving healthcare outcomes, I think that's the best way that we can deliver nursing and midwifery.
Okay, well, last hear from Wu from China.
Thank you. It is my great honor and privilege to be part of this panel on behalf of the President of the Chinese Nursing Association, introduce you the Chinese model of nursing regulation. Now, the purpose of the nursing regulation is to protect the public. However, safe nursing practice not only depends on the competencies of nurses, but also depends on staffing and the safe working environment. So we designed our nursing regulation system in a more broad way, move from only focus on individual nurses to also focus on the institute where nursing care provided. So the Chinese Nursing Association worked closely with the Chief Nurse Office and designed this kind of regulatory model. And the nursing ordinance was released in 2008, which includes 5 parts that guide nursing regulation in China. So part 1, there are some difference from other countries. Besides specifies the legal status of nurses and the regulatory body, which is the provincial health bureau, it clearly requires the relevant departments of the state council and the local governments to take necessary actions to improve the working conditions of nurses and guarantee the welfare of nurses. And the third part is about licensure, registration, rights, and obligation of nurses, which is similar to the other countries. And the fourth part are different from the other countries. It clarifies the duties of healthcare institutes in terms of staffing, protecting the rights and the interests of nurses, etc. And the last part also is about the legal liability of nurses, both nurses and the healthcare institutes. So the last year was the 10th anniversary of this implementation of our new regulatory system. We conducted a national survey which included 210,000 nurses from 31 provinces to evaluate its effectiveness. We found that the number of nurses increased dramatically from 1.5 million in 2007 to 4 million in 2018. And the profile and the status of nurses improved dramatically. Nurses are equally paid, and we don't have any salary differences between male and female, and between nurses and the physicians if we get the same education and credentials. And the working condition for nurses has been improved dramatically also, and so as the safety and the satisfaction of the patients. But we still have challenges because the nursing ordinance is not a law. So we are now working on the development and the release of nursing law. We also realize that producing competent nursing graduates are more important. So with the effort made from the nursing academic sector, the Ministry of Education established a separate accreditation committee for nursing education. In China, there are only 2 independent accreditation committees for professional nursing education, and nursing is one of the 2. And I'm very honored and privileged to be appointed by the Ministry of Education as the chair of the committee. Thank you.
So I want to thank all our panelists for sharing innovations from each of their countries. There were actually a couple themes that I think I heard. One was collaboration between the professionals and the regulator, and addressing things like work environment, addressing the scope of practice. We also heard process changes, automation and speeding up the ability to carry out the regulatory process, as well as streamline the ability to address advanced practice. And the interaction between working conditions that allow safe practice are also really critical in terms of recognizing that nurses can't provide safe care unless their work environment and their working conditions are conducive to that. So I'm going to turn back to our 2 experts, David and Mercedes. As you've heard some of the examples that were provided, and you think about where regulation is headed in the future, give us your perspective and reaction to what you heard, and how perhaps some of those match with the themes of other global changes that will strengthen our approaches to regulation.
Thank you, Pam, and I want to thank all of the panelists for really sharing with us some amazing pieces of work. And I would describe it, first of all, as regulatory reform in action, including the presentation that Mercedes gave us, because each of them identified solutions to policy and practice problems. They used innovation to address them. they certainly drew together a collaborative stakeholder approach. And I also heard in a couple of the examples, inbuilt evaluation as well. So I would say that if you take only one word away from the conference, I would actually say the word is SPICE. Solutions, policy and practice problems, innovation, collaboration and evaluation. And it gives you, as a result, because I heard what I would describe as M to the power of 6, more efficiency, a more modern regulatory environment, more services for patients, more opportunities for the profession, more harmonization in terms of alignment, and more best practices. So in my mind, regulatory reform in action, SPICE equals M to the power of 6.
Bueno, pues coincido con el doctor Benton. Felicidades por todas las iniciativas. Es verdad que la regulación es el medio, pero creo que en el fondo de todo esto, al final, es el para qué se está regulando. No debemos perder el objetivo, que es el de garantizar esas buenas prácticas en beneficio de los pacientes. Y evidentemente todo esto tiene que pasar por procesos regulatorios, procesos de diseño, procesos de investigación, procesos de evaluación, que son los que te van a permitir medir de qué manera los profesionales de enfermería somos capaces de llevar a cabo estas buenas prácticas. Si tuviera que quedarme con alguna palabra sería, o con algún mensaje, ¿no? La regulación para la seguridad del paciente, también para la seguridad de los profesionales en base a estos entornos seguros, que son necesarios, porque si no hay entornos seguros, pues ni estamos seguros los profesionales, ni vamos a poder proporcionar cuidados de calidad para los pacientes.
Thank you very much. Again, I think you're hearing a real call to continue the collaboration, to be able to live up to the importance of protection at all levels of practice. I like the problem solving, reform in action, and really focusing on the connection with safety at every level. Now, our speakers have been so good at keeping to their time frame that we do have a few minutes for questions from the audience. And I do see that our microphones are still there. So if there's someone who would like to give a question to our panelists, and if you would identify your name and country, and then if you have a particular person you would like to direct your question to.
Hello, everyone. Hello from Georgian. I'm Iya Gelenice. I represent my organization, a head of organization from Georgia, and I'm proud to be here, and proud to be a nurse. And I have actually for all presenters now question. What will be your gold recommendation for this country, developing country, who only just now start in your country development, regulation development systems? And this will be very great for to understand what is the specific concepts on this side. Thank you.
Okay, could you just state that again? What is the recommendation for a country that is just beginning the steps?
To get the steps for the regulation development.
Okay, is there someone who would like to address that? You want to pass with the mic? Thank you.
I would say have a strong piece of legislation, but I think my goal would be, again, that collaboration, and again, making sure that, the professional associations works with the regulator works with the professional associations, works with the unions, and that everybody respects each other's roles and responsibilities, because together I think we're much more powerful than alone.
Yeah, thank you.
I would add that you're actually in a privileged position because you've got no history. And it's often easier to come up with new, innovative ideas when you don't have to deal with the history. So I would encourage you to go as far and as fast as you can and don't get tied down in out-of-date examples from other countries. Really think about what you need to move forward the healthcare in your country and the profession that is serving the citizens.
Thank you.
Thank you. To this side, yes, Mexico.
Sara Alicia Ponce de León de México. Hace muchos años hemos estado trabajando con la regulación y la legislación en enfermería. Creo que vamos caminando y creo que es un esfuerzo de todos los países por tener su propio proyecto. Y me parece que lo que más importante es que en cada país tiene sus características específicas, pero creo que nos debe guiar una intención de hacer cosas nuevas, de no seguir haciendo más de lo mismo. Yo agradezco toda la visión que nos han dado en la presentación, porque han aportado las características propias de sus propios proyectos. Por ejemplo, en México no queremos usar ya lo que hacíamos antes de usar reglamentación de enfermería, porque nuestra Constitución marca que esta reglamentación es hecha solo por el sistema de salud. Y entonces siempre quedamos mal las enfermeras, porque son los médicos siempre los que lo han hecho. Y en cambio, si nosotros hablamos de legislación, lo ponemos a consideración de otros profesionales, pero senadores y diputados. Nos va bien hacer eso. Me llamó mucho la atención porque ha ido coincidiendo con España, que en México ya también se hizo una legislación de la prescripción de las enfermeras y los enfermeros, que vale la pena decir, siempre hemos prescrito. Pero que una situación que es muy importante es que cambiemos esta orientación también de enfermería. Yo he trabajado en diferentes áreas de enfermería y hospitalaria y comunitaria y ahora he estado trabajando para hacer un diagnóstico de la situación de salud y los estilos de vida en una comunidad rural. Lo hago los fines de semana porque no tiene mucho que ver con mi trabajo. Pero yo creo que es algo bien importante que hagamos. Y cada quien debe adaptarlo a su propio país y es lo que han mostrado y me parece muy enriquecedor. Muchas gracias.
Thank you very much. One last very quick question here.
Thank you. Sarah Burje from Kenya. I'm the Deputy Registrar of the Nursing Council. I'm interested in Ghanaian model because our licensure exam is paper-based, and I want to know how you arrived at online licensure exam. And also you said you had 17 and you went down to 10, so I would like to understand how that happened. Thank you.
Thank you. It is something interesting that we also love to share with you. And so I have my complimentary cards here, and after the session you may come. But the good thing is that we have been proactive, and because we have become a hub in the West African sub-region, we have even started mentoring other countries. And it is interesting to note that 3 weeks ago, through our initiative, our friends from Liberia were in Ghana to understudy our operations. And my colleague registrar is here from Liberia. Cecilia, are you around? Can you stand to your feet? Thank you. Yes, so we are happy to collaborate with you. Thank you.
Thank you for your comments and questions, too. And I want to thank all of our panelists now. Please join me in a round of applause for their sharing of all of the innovative ideas that we might take home with us. So I encourage you to be back in your seats at 4 o'clock for a very, very meaningful closing session. Thank you.